Welcome back, students, to Decode Healthcare with Harshal. Today, we are jumping right into our masterclass explainer on MDC01 and MDC02. We'll be navigating the incredibly complex world of inpatient coding and DRGs, focusing our analytical lens specifically on the nervous system and eye disorders.
Now, really quickly, before we dive in, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Your support is exactly what allows us to keep breaking down these advanced healthcare concepts for you week after week.
All right, let's get right into it with a super quick recap of Part 42. Last time, we untangled those absolutely critical sequencing rules for conditions present on admission, or POA, versus hospital-acquired conditions. Remember, accurately capturing whether a condition like a deep vein thrombosis or a stage 4 pressure ulcer was present when the patient walked through the door completely shifts the DRG weight and the hospital's quality reporting. It's literally the bedrock of clinical documentation.
Here is our syllabus for today's explainer. 1. MDC01 covering the nervous system. 2. MDC02 for eye disorders. 3. CDI precision. And finally, 4. A quick summary plus our Part 44 teaser.
Section 1. MDC01, Diseases and Disorders of the Nervous System. Let's dive right in. Looking at the ICD-10 PCS guidelines, it's pretty fascinating how the central nervous system is mapped out physiologically. It's represented by the body system value 0. This covers the whole shebang, procedures performed on the brain, spinal cord, and peripheral nerves. So whenever you see a medical or surgical procedure code starting with the 0 in this section, you immediately know you are navigating the central nervous system.
The scope of MDC01 is literally massive. It captures high acuity, incredibly complex diagnoses. We're talking life-altering events here: ischemic and hemorrhagic strokes, transient ischemic attacks, major seizure disorders, meningitis, and multiple sclerosis. These are patients who require intense resources, which is exactly why the DRG assignments in this category are so heavily scrutinized by both coders and auditors.
So, when we process these cases, the grouper logic first hunts for a major partition. Basically, it asks, was this a medical admission or did the patient need the operating room? On one hand, we have major surgical DRGs like craniotomies or spinal OR procedures. And on the other, we have standard medical, stroke, or TIA admissions with absolutely no surgical intervention.
And you know, this surgical partition is strictly defined in our updated guidelines. Take a look at the revised titles for MSDRGs 023 and 024. To actually land in these specific surgical DRGs, the craniotomy has to be accompanied by something like a major device implant, an acute complex CNS principal diagnosis, an antineoplastic implant, or epilepsy with a neurostimulator. It's not just about the surgery itself, it's about the complexity of the accompanying diagnosis or device.
Now, imagine a patient rushing into the emergency department with symptoms of a severe acute stroke. A massive DRG driver in MDC01 is thrombolytic agent administration. Get this, according to our coding guidelines, if that patient receives TPA or TNK and the stroke is quote-unquote aborted, it is still coded as a CVA. Why? Well, because even if the brain damage isn't visible on a CT scan, microscopic changes have still occurred. You absolutely must capture this to reflect the true severity of the case.
All right, moving on to Section 2. MDC02, Eye Disorders.
In our ICD-10 PCS world, the eye and all its related structures are entirely mapped to body system character 8. This single character is your map for everything from a routine cataract removal all the way up to a highly complex corneal transplant.
Now, time for a quick reality check for us inpatient coders. Acute inpatient admissions for MDC02, they are actually pretty rare. Most eye procedures are handled strictly in the outpatient setting. For a patient to be admitted as a true inpatient under MDC02, they usually have to meet some really severe clinical criteria. We're talking aggressive orbital cellulitis, severe traumatic ocular injuries, complex retinal detachments, or deep infections like endophthalmitis.
When those uncommon admissions do actually require an operating room procedure, the DRG logic splits them up again. The surgical DRGs are carefully partitioned into intraocular procedures, meaning inside the eyeball itself, versus extraocular procedures, which involve the structures surrounding the eye. Nailing down this specific anatomical approach is completely key to accurate DRG assignment.
Section 3. CDI and Documentation Precision.
Let's really funnel down into the micro details here.
Okay, this is where the magic happens. In the real world of documentation, relying on vague terminology is basically a recipe for lost revenue. As outlined in our specialty guidelines for neurology, if a physician just jots down history of stroke without specifying the exact time frame, the etiology, or whether it involved the dominant or non-dominant hemisphere, boom, the coder is forced to default to a lower-paying DRG. Vague documentation literally halts the revenue cycle and prevents you from capturing the patient's true severity of illness.
To protect that revenue integrity, your documentation literally has to be laser-focused. Think about a patient with a cerebral infarction. We need the details. Was it embolic or thrombotic? What is the exact arterial site? And crucially, what are the residual deficits? Capturing secondary manifestations like hemiplegia, aphasia, or dysphagia is often exactly what bumps a standard case up to one with a complication or comorbidity, a CC, or even a major CC.
Let's see how this builds into our scoring systems, because honestly, this is a super common trap. We apply a strict rule of contrast here. When do we code the Glasgow Coma Scale versus the NIH Stroke Scale? Well, according to the guidelines, the Glasgow Coma Scale is used exclusively for traumatic head injuries, intracerebral hemorrhages, subdural hemorrhages, and subarachnoid hemorrhages. Conversely, you reserve the NIHSS solely for acute CVA cases. Do not mix these up, or for sure your secondary diagnoses will be rejected.
So, what's the golden rule for capturing all this? Show your work. Daily progress notes are the absolute lifeblood of inpatient coding. Just writing stroke on day one, not going to cut it. You must document the active treatment and monitoring of all secondary conditions. If the patient develops dysphagia and needs a speech-language pathology consult, write it down. If their coma score fluctuates, document it. This clinical correlation provides the objective evidence you need to capture those critical CCs and MCCs.
Section 4, Summary, and Part 44 Teaser.
Let's pan back out and look at the MSDRG triplet structure. It becomes super clear, right? While your principal diagnosis, say that acute cerebral infarction, determines the major diagnostic category, it is your consistent application of CDI precision that actually matters most at the end of the day. Capturing those secondary deficits, the TPA administration, and the precise surgical approaches is exactly what secures the highest, most appropriate level in this DRG triplet, whether it's without a CC, with a CC, or with an MCC.
And just like that, we've wrapped up our deep dive into MDC 01 and 02. But hey, don't put those pens away just yet. Get your notes ready, because in Part 44, we are tackling the high-stakes coding rules and partitions for MDC 03 and MDC 04, covering the ear, nose, throat, and respiratory systems. Think pneumonia, ventilators, and complex airway procedures. It's going to be a big one. Thank you so much for your dedication to mastering this material today. Remember, as a coder, you aren't just processing paperwork. You are translating the true severity of a patient's story into the very data that sustains our entire healthcare system. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Keep studying, and I will see you in the next explainer.